Assalamu alaikum and good evening, everybody. Hope in this stressful time all of you are doing well. Today we are going to have the last session of this term before the Ramadan. After Ramadan, we'll be starting again afresh and hopefully in a better situation regarding the COVID infection. আমি একটু পরে কথা বলছি। Today, Professor Rafique sir, our teacher, our mentor, our beloved founder of electrophysiology in this country, he's going to present some interesting cases. And as sir was saying, he'll be going not in a specific way, but encompassing the usual problem that we may face in our clinical practice. I hope all of us are going to enjoy the session and learning will be as ever much more with his presentation. He has the unique capability of presenting very complex things in a very suitable, easy, digestible way, which we can easily remember. Sir, we are waiting for your veritable presentation.
Good afternoon and Assalamu alaikum. So thank you all. It's a difficult time in Bangladesh, actually all over the world. Even in the United States, there is big surge in the COVID. And hopefully the vaccination will make some impact on the whole thing. I mean, I think there is some impact. If we look at the people who are affected and got vaccine, they probably have milder disease. And if we can spread it. The other issue is that with the precautions. Unfortunately, people get careless. I hope that all of you who are listening send a message to people that look, take the vaccine and even with the vaccine, take precaution. What I want to do today is I want to wrap up the whole session that we did. So instead of a lecture, what we Wadud mentioned is going to be I'm going to give ECG questions, and then we may discuss the management a little bit if we have time. So I'm going to share my screen. So Rivu, we are going to do this. We'll give the ECG about 30 seconds, and then we'll have the poll, right?
Okay, yes, sir.
We can do that, okay.
Sir, we'll keep the poll for 30 seconds?
Yes, please. And then I would like everybody, there are two participants, including us, I would like all of you to answer. I mean, it doesn't matter. You look at the ECG, you say what you think. And then we discuss what is right or wrong. As I have always mentioned, that it is something that we have to, anything that we say, we have to make some comment without being overconfident that I am always right. It applies to me. I was giving lecture to the residents. After 30 years, I still make mistakes, and I still learn. It depends on how meticulously I'm looking at it. There are mistakes. There are sometimes in a rush, we ignore things. So there is nothing wrong with that. But the question is perfection. And as I give these talks, I'm actually learning. And number one. Number two is I'm refreshing what I know before. Some of the things that I keep, it gets erased from the memory. And then when I teach, I learn those things. So this is my first ECG. And there are choices. Please look at it carefully. This has grids and everything. When you look at it, you should come up with an instant diagnosis and then look at the numbers also. Don't just rely on your intuition that, oh, I'm right. This is abnormal. This is normal. Don't say like that. So please look carefully. And then, will it be possible to bring somebody up to talk about it? One from the participants, that will be great.
Haribu.
Sir, if you invite someone, we can call from the attendees.
No. Make them panelists so that they can communicate with.
Sir, if you select someone, I can bring that person to the panelist then from attendees.
Now, do you have their phone number? You can call them just.
Uh,
Well, she'll do it. She can let her take care of the way she feels comfortable. All right, let's get the poll. Okay,
B. A
that's
and B.
good. I mean, we have all the choices and we have all the answers. And I'm glad that a lot of people answered. So do you want to invite anybody from the panel, or shall I let me look at this, and I'm going to do this, and then. So the question is, everybody agree that this is sinus rhythm. I mean, I did not put any other diagnosis to this, but am I right? So let's look at the. So I put up I took the P waves and I put them in different locations where they should be. If you can see, the AVR is on the right side, AVL is on the left side. And if this black dot is the sinus node, and if this impulse is coming from here, it will go down towards lead 2, 2, AVF, and 3. This is lead 2, I'm sorry, here, lead 2, AVF, and 3.
Hello.
Let me move this bar. Okay, so you can see that the lead 2, 3 AVF, the P wave is upright. What it means that it is moving towards it. Now, this 3 lead by itself is not good enough. Why? We also need to look at lead 1. If it is coming from the right side, the lead 1 will be positive, and that makes it sinus rhythm. You can have a rhythm coming from left atrial appendage where my pointer is. Let me change my pointer. Where my pointer is, that ECG will also give positive in 2, 3 AVF, but not in lead 1 or AVL. So if you find a rhythm where it's upright in 2, 3 AVF and lead 1 and AVL is negative, that's probably a left atrial rhythm that's coming from the top. A lot of times it comes from left atrial appendage. So that's what it is. So this is sinus rhythm. So we all agree on that. The question is the QRS axis. Is it normal or abnormal? Lead 1 is positive, so it's on the right side. Lead AVF is negative. It's on the top. So it is between 0 and minus 90 degrees. Now, let's look at another lead 2. Lead 2 is positive. Here is lead 2. If lead 2 is positive, it will be between 0 and 30 degrees. So that's an acceptable normal range of axis. So the rhythm is sinus, QRS axis is normal. So even though I put all those diagnoses, none of them are actually correct. So it's basically this is number 2 is correct. It's a normal rhythm. So whoever answered all those others, so they are very closed thing. But please remember, please measure it. Please look at it, and also remember, please keep a visual image of this ECG. This is the ECG that encompasses 90% of ECG in a clinical practice, unless we get referred patients. So normal ECG. Thank you all.
Sir, can I ask?
Yeah.
Sir, the first ECG, sir.
Yeah.
Sir, the number 3 choice is sinus rhythm, left anterior fascicular block.
Yes.
Sir, is there any variation of duration in case of the fascicular block?
The question is, if there is left anterior fascicular block, will there be a QRS duration change? Maybe. Why? Because the other two fascicles are in good condition. So usually what we use is the QRS axis, because left posterior fascicle, right bundle are going to conduct as usual. But most of the time you may see some duration, but the criteria for left anterior fascicular block varies, but normally people will say more than minus 45 degree, and then there's a small Q in lead 1 and small R in lead 3. Here I have a small R in lead 3, but not a small Q. And the QRS axis, of course, is. So mainly the diagnostic criteria is the axis and presence of those Q wave in lead 1 and lead 3, R wave. Thank you, Atahar.
Is that?
Okay.
Volunteer participant can raise hand, please.
Okay, that's good. So Wadud or Atahar, one of you want to comment on this, then I will pitch in. Majority of the people say junctional rhythm with retrograde P wave, and 22% said left atrial rhythm, and then sinus rhythm with short PR and sinus rhythm normally ECG 1 and 1%.
And
Majority. Okay.
Ribu, is there any volunteer participant, Ribu?
Yes, let's get somebody.
Sir, in the panelists now there is Mr. Buddhadev Ganguly and Lieutenant Colonel Nizamul Hossain Chowdhury.
Can you connect any one of them?
Sir, they are in the panelist. I'm asking them to unmute.
Nizam, can you describe and what is your decision? Dr. Nizam, are you there? Or Buddhadev, are you there with us?
Poppy Bala, can you unmute yourself, Poppy Bala?
Yes, sir.
Poppy Bala, can you describe the ECG?
So this is a 12 lead ECG, surface ECG. The speed is 25 with a rate is around more than 80 beat per minute. Rhythm is regular. There is a inverted P followed by QRS complex in the 2-3 AVF and all the precordial lead except V1 and AVR. And there are some non-specific STT chains can be seen throughout the ECG, sir.
So what is the diagnosis?
Sir, most probably it is a left atrial rhythm with non-specific STT changes, sir.
Okay, yeah. So let's look at it. I mean, because we have vote, And both make sense. One is junctional rhythm with retrograde P wave. So let's address that. If there is a junctional rhythm, it comes from the AV node. And then it goes backward into the atrium and forward into the ventricle. Normally, the time to travel from the AV node to the atrium will be about 80 milliseconds. So if it is junctional rhythm, most of the time you will find the retrograde P wave either before or after the QRS within 80 milliseconds of the QRS complex. This one is a little longer, number one. Number two, if it is coming from through the AV node, please visualize the AV node is in the center of the heart. It will come up and then it will go to the right and to the left. That means when it will go to the right, it will go straight up into the V1, it will be positive, which it is. But when it will go to the left, it will make a positive P wave in V1, V6, I'm sorry. So because it is going towards V6. So this, if we look at this one, here is, I have superimposed this on a grid. If you look at V1, fine, positive. And then all of them will lead on it. So that can only, if it was coming from here, it will go towards V6 and V6 would have been positive or kind of flat. The fact that it is negative in V6, that means it is moving away from V6. And V6 is near the left atrium. So it is a left atrial rhythm. And so it is supported by the few facts. The PR interval is longer than 80 milliseconds. And then it is negative in left leads. That means V6, V5, V4. So this is a left atrial rhythm. AVL, if you look at, is kind of positive. Why? Because AVL is a little higher up. So this is actually moving a little bit towards the AVL also. So I think that may have confused people that how come the AVL is positive, because AVL is not in the lower part of the left atrium. So it's the left atrial rhythm. And unless anybody else have any other comment.
Can I comment, sir?
Yes, please.
Sir,
Please.
Left atrial rhythm, in that case, lead 1, P wave here is inconspicuous.
Yes.
Either positive or negative, we cannot mention here.
Yes. So it's kind of flattened.
Flattened.
Yeah, I mean, I can't even see. So then I can't make any comment on that. So the lead 1 is somewhere up here.
Yes.
So AVL is a little higher than lead 1. So I think that's what it is. So this is a left atrial rhythm. And it's very typical.
Any terms for low atrial rhythm? Is there any term?
Well, yeah. I mean, listen, it's like if you call it if somebody told me this is an atrial rhythm, I will accept it. If you say low atrial rhythm, I will accept it. Then it becomes more specific. So atrial rhythm will be a broad term for this rhythm, which will include sinus rhythm also. And then if you say low atrial rhythm, I will take it because it is coming from the lower part of the atrium, because 2,3 AVF is negative. And then we want to be a little bit more specific. Is it right or left? And then if you call me left atrial rhythm, I will accept it.
And
More.
Is there any P wave and QRS complex, that means R wave, PR interval is more shorter if junctional rhythm or than low atrial rhythm or atrial rhythm? Is there any?
Absolutely. You're absolutely right. The PR interval will be shorter. That's what I said, that usually the P wave will be within 80 milliseconds of the QRS complex in case of junctional rhythm. Yes, unless there is very rarely you can find longer, but that's very, very unusual. But we should always think what is normal. So as Dr. Paul mentioned, that if we call it an atrial rhythm, I'll take it. If you call it a low atrial rhythm, I will accept it. And of course, I will like it very much if you call it left atrial rhythm.
Sir, I have a question, sir.
Yes.
Sir,
Yes.
For this case, sir, we want to hear some few comments regarding the management, that is symptomatic versus asymptomatic. This case, sir, management.
This patient was totally asymptomatic. I mean, and you'll find a lot of these ECGs. They have actually left atrial, they have no symptoms. So this, unless they become tachycardic, when it becomes left atrial tachycardia, this is within normal range. They have no clinical symptom at all. So do nothing about it. We'll keep a note of it.
I have seen many patients, sir, with left atrial, low left atrial rhythm, and they are, as you were saying, totally asymptomatic.
Yes. Thank you. Any other comment? No.
In that case, no treatment is required. Is there any other risk factor or cause like ischemic heart disease, like chronic coronary syndrome, others?
No, the question is if there's any relation with any structural heart disease. No, most of the time it is something. Secondly, it has no relevance because it's the atrial issue. It has not much of a relevance to coronary artery disease. I mean, of course, the STT segment change, you have to keep an eye on it, whether patient has hypertension or anything, or that will be decided by the clinical presentation of the patient based on the STT segment change. That's a different issue beyond the rhythm problem itself.
Sir, can I ask a question, sir?
Yes.
A few patient with structural heart disease before operation or before device closure, we get this type of low atrial focus, sir. So
Yes.
on that occasion, what precaution or what will be counseling to the parents that after surgery or after device closure, what can happen, sir?
And now we are talking about pediatric domain, right?
Right, sir.
Yeah, pediatric patient has more junctional rhythm. That's interesting. Pediatric post-surgery patient gets junctional tachycardia, junctional rhythm. I think again the management will be based on the symptom and
No,
what the
sir,
heart rate is.
I'm telling before operation or before procedural intervention, we get sometimes this finding.
Yes. Yeah, I mean we keep a note on it of it, but I don't think an atrial rhythm with the heart rate, if the heart rate is 87 or whatever rate is below 100, we'll just keep an eye on it. Nothing to be worried about. This will not prohibit the patient from getting surgery.
Sir, one question from Ojoy, consultant from Silet. Why SNOD is suppressed here?
Oh,
is there any reason behind?
Well, I mean, one of the two things. One, I have no follow-up. Unfortunately, a lot of patients I have follow-up ECG. One, maybe there are two rhythms. They're competing with each other. Maybe the sinus was a little slower than that. I mean, you'll see that happens. That there is sinus bradycardia, then you get left atrial rhythm. On the other hand, you can also see accelerated left atrial rhythm. And as I told you, that unless the rate becomes an issue, we just don't do anything about it. They keep flipping back and forth. And most of these patients are asymptomatic. These are patients that we find on routine random ECGs. Thank you.
Thank you, sir.
Govindo, we will discuss this ECG, Govindo.
Yeah. Okay, good.
After result of a pool.
Right, after result of pool, right.
I'm glad that majority are answering, and there are now 79. So I think more people should answer these questions. So we have 13 people answered. So the poll is done. Majority said it's sinus tachycardia with ventricular premature beat. Govinda, any comment?
Yes, sir. 12-lead ECG shows ventricular rate more than 100, and it's sinus rhythm and some premature ventricular complex in V4, V5, and V6, and also in only 3 leads, a few premature ventricular complex, but otherwise it's sinus rhythm and sinus tachycardia. That means sinus tachycardia with occasional premature ventricular complex.
Can I make a comment, sir?
Yes, please.
Number one, it's a simultaneous reading. So the so-called premature beat you are seeing, a single premature beat. Now, look at the same time the rhythm strip, which is recording at the same time. All the QRS complexes are corresponding. Look at this. That premature beat is not present in here. So this is likely to be an electrical aberration. So I would go for sinus tachycardia with non-specific T-wave changes.
Anybody else want to comment, or shall I wrap
Sadi
it up?
Sadi bhai or Jamil bhai?
There is, look at this, there is also the T-wave inversion or pause, nothing is there. So it's difficult to know whether it is an actual premature beat.
Moreover, there is P wave ahead.
And PF, normal P-wave.
Normal P wave.
P-wave seems to be little peaked, but duration and height is almost normal. One beat seems to be ventricular ectopic, but that's an artificial deflection. I go with the 4, what Wadud said.
Yes, points against is the preceding P wave. If P wave is present, ventricular ectopics, then we can tell it's premature ventricular ectopics.
The P-wave occurring at the same time and the beat, look at the R interval.
Yes, sir.
It's premature? It is not.
Quite complex.
It's not premature, and it's there is no compensatory
Most probably artifacts already.
Yeah.
Okay.
Interpolated ectopic. Sir, interpolated ectopic could be things, but it's never corresponds with the rhythm stream. That is why it is not the.
So, I mean, I found this ECG, I found it interesting. It is sinus tachycardia, no question about it. There is non-specific T-wave changes. If you look in lead V6, it looks like a wide QRS ventricular beat, even though the beat is not premature. I'll come to the bottom of the strip later, but if you look at V4, the beginning looks exactly like the normal QRS count. And then, of course, as Wadud mentioned, in lead 2, which is the rhythm strip in the bottom, there are simultaneous, there is no change, and the PR interval is normal. So this is the common, I mean, please keep an eye on this. I mean, we'll see this kind of ECG, and if this kind of rhythm becomes multiple, you can have artificial ventricular tachycardia. We see it all the time on the rhythm strips on telemetry monitors. So this is sinus tachycardia with non-specific T-wave changes. The other thing, please remember, I use the term premature beat. This beat by caliper is not premature. So if it is a wide QRS beat, we'd have to think something else. Is there a left bundle branch buck aberration? Or is there a very late ventricular beat that is coming exactly at the same time, which will be very, very difficult to happen. And as Dr. Shafiq mentioned, if it is interpolated, you will see it in the middle of between 2 QRS complexes. So this is sinus tachycardia. Thank you all.
Sir, one question, sir.
Yeah.
Sir, previous issue, sir. Sir, at the same time, and the rhythm strip at the bottom, that is lead 2, whether the sir, that beat, whether corresponds with the same, sir. should we consider that that is the beat in the rhythm strip as a standard for comparison?
Yeah. Well, in our machines, yes. It depends. If you, most machines, if they record it at the same time, it is the same beat. And I'm in Bangladesh, the older machines were not, but now all the machines are all over the world are like that. The rhythm strip, some of the machines will put one lead, some put 3 leads, which makes it very confusing, more confusing, having 3 rhythm strips. But I like it 1 rhythm strip. So this is simultaneous.
Thank you, sir.
Thank you. Please don't think too complex. Please remember, we are wrapping it up. In real life practice, not all ECGs are complex ECGs. Simple things are also there. If you look at somebody who looks like Dr. Shafique, that's Dr. Shafique. It's not somebody else. This is good. So who will comment on this? Dr. Shafique, you want to talk about it?
Shafique, please.
I already unmuted myself. So this is definitely, but it seems to be 3. So this is 3 is correct because this is atrial fibrillation, never atrial flutter, because waves are not sawtooth, but a bit sawtooth in V2 earlier part, but later on it's in other parts it's not sawtooth shaped. So it is atrial fibrillation and slow ventricular rate. Ventricular rate is slow, and at the same time there is poor wave progression from V1 to V5 definitely. So I would go with 3, sir.
Yeah, thank you. So whoever answered flutter, of course, looked at those waves, and as Dr. Shafique mentioned, you can see these organized waves, but actually it's very disorganized. And this is fibrillation. We call it coarse atrial fibrillation. And number 2 is partially correct. But when you look at an ECG, please also look at other things. The poor RF progression. What it means, clinical significance, that's a different story. You have to go through the differential diagnosis of it. Thank you. And the atrial fibrillation, we don't want to talk about management, but remember anticoagulation issue, duration of the atrial fibrillation, whether to do, what to do about it, all those things should be taken into consideration. Thank you.
Sir, one question, sir.
Yeah.
Sir, is there any term flutter and fibrillation simultaneously? Sometimes we tell you that is a flutter fibrillation.
Yeah, we use the term flutter fibrillation, but you know, it's the problem is like sometimes we have actually recorded signals. In many years ago, we used to put a catheter in the coronary sinus in patients with atrial fibrillation, and that coronary sinus electrode will connect to one of the channels in the Holter monitor, and then we will also do the surface. And we would find that the patient is in atrial fibrillation and the left side is in flutter. So some people do use it if there is a combination of that. But I think that's a pretty vague term. I try to avoid it. It's like not committing yourself. I think in this case, this is clearly atrial fibrillation.
Sir, one management related question, sir.
Yeah.
Sir, that is the first episode of atrial fibrillation. Sometimes we face this patient, yeah. And we, sir, we advise that is the anticoagulant. But after follow-up, how long we should continue the anticoagulant if there is no atrial fibrillation again, 6 months, 12 months like this? Is there any?
Yeah, I mean, the question is how long to continue. Once what we practice is once we document atrial fibrillation in a patient, we use the Chowdhury score. Even if they maintain sinus rhythm, we will continue anticoagulation based on the Chowdhury score. Because sometimes it may happen these patients can have very brief episode of atrial fibrillation where they are asymptomatic. So unless there is a contraindication, they should be anticoagulated based on the Chowdhury score. That is our practice. Thank you.
We have got Arun Musk with us, sir.
Oh, Arun, how are you doing?
Arun Musk, unmute yourself.
Is Motion online? Motion?
Motion, unmute, please.
Okay. So we have everything. We have everything here. Majority said ectopic atrial tachycardia or atrial flutter with 2-to-1 conduction. A motion is there.
Motion. Sadi bhai.
Anybody?
Sadi bhai. Arun Maski, can you hear us?
Atahar, why don't you do this?
Is there any participant? Rivu?
Oh yeah.
Sir,
Yes.
sir, one participant raised his hands.
Okay.
Saifuddin.
Yes, please.
Okay.
Saifuddin Chowdhury.
Saifuddin
Okay.
Chowdhury.
He's in the panelist now.
Okay, okay. Saifuddin Chowdhury. Hello, Saifuddin Chowdhury. Unmute, please.
Saifuddin, can you unmute and respond?
Sir, I think
the communication probably is the problem.
Yes, yes. Poppy Bala. Hello. Govindo.
Sir, I have a comment. I am disagree with atrial flutter with 2:1 conduction with incomplete RBB. I support here the ectopic atrial tachycardia with incomplete right bundle branch block.
Okay.
Because POA morphology is different from sinus, and also exactly RR interval is not 150 per minute. That means 2:1 conduction in case of atrial flutter with 2:1 conduction. In that case, here rate is not exactly 150.
Jamil.
Sir.
And POA morphology is deviated from sinus.
Yeah.
To me, it most likely it is atrial flutter with twist 1 AV block with incomplete right bundle block. Second possibility, what Govinda said.
Okay. So let's look at it. Some people say sinus tachycardia with incomplete right bundle branch block. Clearly, there is a P wave before QRS complex, but that P wave is negative in 2,3 AVF. So sinus tachycardia with incomplete right bundle branch block is out of the question. Second question is it atrial fibrillation with rapid ventricular response? It is very regular. Once it is very regular, the atrial fibrillation goes out. So we are now left with atrial flutter with 2-to-1 conduction with incomplete or ectopic atrial tachycardia. These are both valid options. And if I use a little bit of imagination, I can say, well, this is either T wave or this is the second flutter wave. And if my theory is correct, then if I put a caliper, they will match up. And if you look at lead 3, it looks kind of funny, but that does not really confirm it. But both are valid options. If you remove the QRS in your brain, you will see it looks like a saw. So what is it? So I always like confirmation. And if you see here that once it slows down, I can see the flutter wave better. And you see this flutter wave, the other flutter wave is now in the QRS complex. And then there is a flutter wave here. And then there is a flutter wave here. So sometimes a little bit of imagination and of course ECG. So this was atrial flutter with 2-to-1 conduction. The rate is a little slow, and Govinda was absolutely right. And that was the confusing part with this ECG. Rate was 114 beats per minute. Normally atrial flutter is 150 beats. Unfortunately, we use amiodarone these days. We use antiarrhythmic medicine, and they make it slow. And sometimes you will find slower atrial flutter. So this flutter rate is basically 228, or a little bit more than 228. And it's 2-to-1 conduction. This flutter is actually very difficult. When the flutter gets slow, it becomes much more of a problem to control their heart rate. Management-wise, anticoagulation, cardioversion at one time, and then if it comes back, this looks like a typical atrial flutter, you can do atrial flutter ablation, and the success rate of atrial flutter ablation is close to 100%. And recurrence rate is less than, I quote 5%, but it's way less than that. In the last 25, 30 years, I had only 2 cases where atrial flutter came back after ablation once it is pure atrial flutter. Thank you.
Sir, I have a question, sir.
Yeah.
Sir, in this ECG, it is clear, but sometimes we are confused to categorize that is 2:1, 3:1, that is difficult to count the flutter rate. Sir, yeah. Is there any simple way, sir? But in this ECG clear, but sometimes we are confused, sir.
Of course. I mean, listen, there are cases where you can't tell them. Like yesterday, my wife showed me an ECG and she asked me, what is it? I said, either it's sinus tachycardia or atrial flutter with 2-tone conduction. And we have to put both options in the field, in the diagnosis. So some cases you won't be able to see it. This is very, very clear. As you said, some cases you cannot. But remembering the differential diagnosis is the key for us. And I don't know.
Sir, amiodarone is a good option here.
For supraventricular arrhythmia, we like to avoid amiodarone. As a matter of fact, the use of amiodarone has gone down significantly. Right now, we use amiodarone only for older patients who have atrial fibrillation and cannot take any other medicine to keep them in sinus rhythm. In this case, this is a 86. I mean, this patient probably will go for an ablation or one-time cardioversion. So if this patient came to me first time, one time I'll do anticoagulation with cardioversion. And if it comes back again, then I will do ablation of atrial flutter. And this will work. This is very typical flutter. Okay, so this is a patient whose ejection fraction in August was 55%. Now in April of 2020 was 55%, comes to the hospital with ejection fraction of 30. And this is the ECG. Heart rate is 151. So I'm not trying to make life difficult. The patient is trying to make our life difficult. So what is it?
এটা খুব ইম্পর্টেন্ট ইসিজি।
Yes, and remember, this ECG was done in the hospital while patient is lying comfortably in bed. So that's an issue.
হ্যালো হ্যালো, ওয়ালাইকুম আসসালাম। আপনাদের ওই ট্রিটমেন্টটা কে দিয়েছে? কোভিডের সুন্দর ট্রিটমেন্ট দিয়েছে। ওই কোভিডের ট্রিটমেন্টটা কে দিয়েছে?
Arun Maski, can you hear us?
So we have a good, almost equal distribution of all the choices.
Can I comment, sir?
Yes, please.
12-bit ECG shows sinus rhythm rate around 150 already, 151, and old Q wave and a little bit PR segment is depression in one AVL and ST concave upward elevation in one AVL as well, and also old Q wave in V2, V3, V4, and V5, and also V6. That means old MI anteroseptal with sinus tachycardia, and also background is heart failure and also pericarditis as well.
Okay.
Govindo?
Yes, sir.
Achha, coronary diagnosis is okay, but what about the rhythm?
Rhythm, POAB is lead 3 and lead 2. It's very much difficult to probably sinus rhythm.
Can I make a comment, sir?
Yes, please.
This is a difficult disease, you can comment.
This is actually not difficult. The circumstantial evidence is there. A patient who has been stable, now having reduced ejection fraction with rapid heart rate, which is around 150. Now, look at the P wave presence. It is far away from the QRS complex. In case of sinus tachycardia, the PR interval should have been shortened. Because of the increased sympathetic activity, because of the heart failure, the patient should have PR interval much shorter. And that means the possibility is that this could be a atrial tachycardia or flutter with old anteroseptal MI. And that has reduced the ejection fraction so much.
Anybody else want to comment anything? So clearly the tachycardia rate is 151. If a patient is lying comfortably in bed, unless they're very, very sick, hemodynamic, it is very difficult to get a heart rate of 151. The other thing that I always do is that if I do an ECG now and half an hour later, the heart rate is still 151, that cannot be sinus tachycardia. But still, it's a possibility in this case, but unlikely. Now, there is a P wave before the QRS complex. and the P wave is upright in 2 AVF. 3 is kind of biphasic. If it was AV nodal rent and tachycardia, the P wave will be going from AV node towards the atria, and it will be inverted in lead 2-3 AVF, which it is not. And also it is a long RP tachycardia. The long RP tachycardia is usually sinus tachycardia or atrial tachycardia or atypical AV nodal rent. These are the 3 possibilities. So now let's look at atrial flutter. Let's look at lead V1. You can see that there is a P wave here. There is a P wave here. If there is another P flutter, there should have been one in the middle. There is none. So it is unlikely to be atrial flutter. So the diagnosis most likely in this case is atrial tachycardia with old anteroseptal myocardial infarction. Please remember that I have added it in all cases. Please don't ignore those findings. I'm not sure about this bit, whether this is an artifact or a ventricular premature beat, but it is there consistently. So I'm still confused with this ECG. So I went back on the telemetry floor. My question was either atrial tachycardia or unlikely possibility of sinus tachycardia, but more so than of atrial tachycardia. So this is the ECG, next ECG. This is the rhythm strip. Now you can see that clearly there is a ventricular premature beat, which it was there before. This is sinus rhythm, and then patient goes into this tachycardia. So it was clearly this patient was going in and out of atrial tachycardia, and one of the probably the possibility what happened that patient has tachycardia induced cardiomyopathy. And when the patient converts back to sinus rhythm, this is 12-lead ECG, look at the P wave, is totally different from the first one. Here we have left atrial enlargement and right atrial enlargement, but the other ECG showed a different kind of P wave in V1. So we're keeping an eye, always look back and having curiosity and trying to find out what the answer was. So the diagnosis of this patient was atrial tachycardia.
Sir, first ECG, please, sir.
Yeah.
Sir, as the patient is quite stable, but this is the tachycardia. Sir, is there any role of adenosine for the diagnosis purpose, sir, in this case?
Okay. The question is, will adenosine aid in the diagnosis of this in this situation? If I had a question about a second P wave and I was not sure, yes. But if I put a caliper, in the middle, there is nothing. So this one, probably not. But if you give adenosine, what will happen? 2 things may happen. If the tachycardia stops, you'll be more confused because some atrial tachycardia can respond to adenosine. It is unlikely, but some do. And let's say I give adenosine, if I see the block, it will confirm our diagnosis of atrial tachycardia. But you will still be confused. Well, maybe it is sinus tachycardia with block. So adenosine is not going to be much of a help in this case.
Sir, in temper, can you use the carotid message?
Yes. Carotid sinus massage is a quick way of doing it. As long as you, younger doctors, you should learn this technique, but please remember, before you do carotid sinus massage, please listen to the carotids. That's an important thing. Second, patient must be lying down, not sitting up, because with carotid sinus massage, we can have the high vagal tone and we have pause. And carotid sinus massage, sometimes we do that to create block.
Or we have to look in the rhythm strip. Here, is it T wave or P wave or merges T and P wave?
Yes. I mean, that's the part that what Govinda is saying in rhythm strip, is it the P wave or the T wave? Or it can be both. I mean, that's what makes it very confusing. But if we go in lead V1, that solves the problem. I can see the discrete wave. So that's why looking at multiple lead helps. If you look at lead V1 or lead V3, you can see the discrete P wave at the same time of the what it looks like T wave in lead 2.
Sir,
So
one more
having one,
question. Sir, one
Yeah.
more question, sir. Sir,
Yeah.
whether SADVAS score is also applicable for this atrial tachycardia, sir?
well, not really. I mean, atrial tachycardia is the chest-VAR score. The question is chest-VAR score applicable to atrial tachycardia? No, because the atrium is contracting. So that applies for atrial flutter and atrial fibrillation. Unless you have suspicion of atrial fibrillation or flutter, that's a different story. Because as I mentioned,
can you use just beta blocker, metoprolol after control of heart failure?
this patient, the question is the treatment. The treatment is, yes, of course, because these patients are cardiomyopathy, the first drug that we're going to use is beta blocker. Lot of times atrial tachycardia is very difficult to treat. And the drug that works best are the calcium channel blockers. The problem is this patient has cardiomyopathy now. So calcium channel blocker will be difficult to use. So yes, Govinda is absolutely right. The first drug of choice will be beta blocker. And that's what we did. And she did fine.
And in which beta blocker is more appropriate? Is it metoprolol, bisoprolol, nebivolol?
Cardiomyopathy, our choice, we use
Carvedilol.
If heart failure patients, I prefer carvedilol. But when there is tachycardia, metoprolol is better in controlling tachycardia. Like if somebody has atrial fibrillation, metoprolol is better. For this one, you can randomly choose anyone because there is no data that any one of them is any better than the another one. My preference is metoprolol succinate. I do not use tartrate for heart failure patients with cardiomyopathy. Carvedilol is a choice. And bisoprolol, whichever. All three drugs have been proven to be beneficial in heart failure. My preference for heart failure, number 1 is carvedilol, number 2 metoprolol succinate, number 3 bisoprolol. We don't use bisoprolol much in this country. The problem with heart failure with carvedilol, good thing is that once you have achieved 6.25 milligram, there is benefit, and there is increasing benefit with higher doses. Thank you.
Thank you.
One hour. So we'll continue another 15 minutes and then stop it.
Okay, sir.
This is not an uncommon ECG. Probably one of the commonest of this type of ECGs.
This is Wadud. Wadud is the right person, sir.
Yes, Wadud is the master of this.
আজকে অন্য কেউ বলুক।
No, not.
Ojoy আছে Ojoy. Ojoy, can you respond? Ojoy?
অজয় তো ছিল স্যার।
দেখো তো আছে কিনা? আর কে আছে দেখো তো?
কমেন্ট করেছিল স্যার। মানে প্যানেলিস্ট হিসেবে আছে কিনা স্যার?
রিভু অজয়কে প্যানেলিস্ট করো না।
Whether your teaching has worked.
তাই দেখতেছি স্যার আসলে।
But still 5 good number of physicians answered number 1. So Wadud, can you comment on this, please?
Whenever you get negative complex in lead 1, the possibilities are there is dextrocardia, or there is technical dextrocardia, this is limb lead displacement, or there is posterior hemiblock, or there is a big Q in lead 1 producing this loss of muscle in the lateral wall. Now, in that case, except the limb lead displacement or dextrocardia, the P wave should have been upright. Here the P wave is negative. Let's go to AVR then. In AVR, we actually cannot see any P wave, which should have been negative. But the first complex, part of the QRS complex is positive. So that raised the possibility that this could be either lip lead displacement or dextrocardia. Now let's go to chest leads. Here the R wave is gradually progressing from right side to left side. From V1 to V5, V6, the R wave is gradually increasing. So it's not dextrocardia. The possibility is therefore sinus rhythm, but limb lead misplacement. 2-3 AVF, they are positive. So this is not an ectopic rhythm. And the PR interval also is quite all right.
Good. Thank you. So this is the same patient, earlier ECG. You can see that P wave is upright. So this is the other thing I always tell, that if it was, if there is a Q wave in lead 1, I would expect some Q wave in V6 also, right, Wadud?
Yes.
And that doesn't add up, because it's such a huge big Q wave that means almost like a lateral MI. And that should have reflected in the V6. So thinking globally, I mean, when you look at an ECG, please get into the habit of looking at the corresponding lead. That means lead 1 is a lateral lead. And if there's a Q wave in lateral lead in 1, there should have been a Q wave in V5 or V6, which is absent. And of course, I'm glad that majority answered. So please keep this. This is one of the commonest lead misplacement. Sometimes we will see lead misplacement of V1, V2, V3, giving rise to difficulty in our wave progression and those kind of things. I'm going to, I think we should do these things because we have done difficult ones. These are simpler but relevant. Wadud, any comment, please?
Sir, here it's a very simple ECG, but we have to pay attention to what are the slight abnormalities are present. Obviously, it's a sinus rhythm. There is slight ST segment changes in 1 AVL, also slight, also in lead 2. Look at the axis. The axis is to be at right angle of lead 2, and whether it is on the right side or the left side. If it's on the right side, then lead 3 would have been more positive. It's not, so it's going to the left side. Then in that case, AVL should be positive and it should be the highest positive, and that's it there. But is it the left axial rotation is there? It is left axis deviation. That's a difficult question, because the QRS complex at right angle is just within the margin of normal axis, but left atrial enlargement is obvious.
So I think as Wadud mentioned, subtle changes, we need to keep those in mind. Axis 1 and AVL, 1 is positive, it's on the right side, AVF is negative, it's on the top between 0 and 90, but lead 2 is actually more positive than negative. If you look at the area of the lead 2 is more. So it is between 0 and 30 degrees. So leftward, but it's still within normal range. Yes. So other thing is that it's not biatrial enlargement, it's left atrial enlargement. You can see the deep, wide wave. So the diagnosis I'll take will be sinus rhythm with left atrial enlargement, and other findings that Wadud mentioned. You have to describe those. ST segment depression, what is the clinical relevance of it, that's a different story. But we have to, yeah.
Clinically, whenever I see this patient in a 73-year-old person, female person, I would go for in the echo to find out the LV diastolic dysfunction. That's very likely in this patient.
All right, so shall we do one more and then close it? I'm going to go for an interesting ECG. So we're going to skip through all these things. This one. So I just put lead V1 and lead 2.
Sir, should I start the poll?
Let them look at it. Yeah, why not?
Again, difficult ECG. Jamil, get ready. This is ECG for Jamil. See.
Very good.
Excellent.
Nice response.
3.
Excellent.
Jamil.
It's a Himalayan P wave. Sir.
Epidysynchrony as well.
Jamil is busy. Shafiq, you can comment.
So it is P. This is a very large P, so it seems to be Himalayan P wave, something like that. And PP interval is regular, or interval is regular, but there is no relation with P wave and QRS complex. So this is complete AV dissociation, and red is not that much low. Red is
64, something like that.
64, something like that. So seems to be idioventricular rhythm, but there is no, but it is complete heart blocks. It is complete heart block with right atrial enlargement, and that is very big right atrial enlargement.
So your choice is 3, complete heart block
3
with right atrial enlargement.
Right.
AV dissociation.
AV dissociation is complete AV dissociation is there.
So this is an interesting ECG because this kind of patient, if they are in telemetry floor and goes into complete heart block with asystole, you may think that the P waves are actually QRS complexes. So it has happened. In the EP lab that we're doing study, and then patient went in the heart block. I said to the technician, can you start pacing? And he said, why are you screaming? I said, look at, and what happens when the QRS, so the QRSs are so small. The same patient, this patient had congenital complete heart block. And you can see with the 12 lead, V5, V6, you can see the QRS complex is much taller. But in the dim lead, it is huge right atrial enlargement, big P wave, almost, as he said, Himalayan P waves. So I think we should, and look at this, I put the timing. If you look at the RR timing, there is some variation because it's a junctional escape, junctional rhythm. with underlying complete heart, but P to P interval was exactly constant at 600 milliseconds.
Was it abstain anomaly, sir?
Abstain.
No, this patient was not abstain. Abstains also get, I don't remember this. Let me see. This is the 34
Thank you.
patient. Almost looks like abstain because it looks like 2 QRS complexes here. Abstains actually get double QRS complex. Yes, look at this. I don't have the clinical issues, I can't quote it, but absolutely Himalayan P waves. And then if you look at lead 2, V2, there are 2 QRS complexes. That's very typical for Epstein, actually. I don't remember the clinical scenario of this patient. This is from 2004. I tried to find this patient, but I could not. Without the date of birth, I cannot find it.
Sir,
Yeah.
in the lead to rhythm history,
Yes.
after the QRS complete, there is a small negative deflection. Is it a retrograde P wave again?
No, but it looks like, but if you look at lead V2, look at the QRS. It's a double QRS complexes. This is the second part of the QRS. Epstein get this. It all looks like almost there are 2 QRS complexes next to each other. All right, so I think we should stop here. I mean, I always consider it as a privilege that you all give me this opportunity to present and share my knowledge with you. And what I expect from not all of you, some of you, to bear the torch. We will be here for another few years, who knows how long. But all of us, the faculty who is sitting here, these are passionate people. What is their gain? Gain is sharing the knowledge. And I hope that some of you will do that. In the country, it doesn't matter where you are, give it to others. And also other thing I feel like that if I always tell people that husband-wife couple, they raise most of the time these days 2 children over a period of 40 years. And they're lucky if they grow up as good children. So all of us here, if we can make 2 doctors with knowledge, compassion, that will be our success. And that's the way I look at life. That if what I am doing and all of us are doing, if we can leave behind 2 persons who can give care, compassion with knowledge, and there will be gap in knowledge. We will not ever know everything, but we can make people smile. Or the patient can tell us, well, the doctor was not the best in the world, but he cared. He cared. And I think that is important. The other part is that we cannot cure everything, but we can actually make people feel good that somebody cared for that person. And that is what will make us physician. And thank you again. I'm out of the country, but you call me into this and I'm happy to be part of it. Thank you.
Thank you, sir.
Wadud bhai?
Wadud ফোনে বিজি আছে।
আচ্ছা,
আর তো কিছু নাই অথর্ব আজকে?
না, মানে before concluding the session, Wadud bhai?
জি বলেন।
আচ্ছা, we can take few comments from our panelists before concluding the session, and finally I will conclude the session. Actually,
ভাই আছে।
we have got good number. আচ্ছা, is there our international faculty Arun Maski?
I could not see him.
Sir, Dr. Urmaski sir is not here right now.
First of all, our pediatric faculty, Naharuma, you are here?
Yes, sir. I am here, sir.
Naharuma, actually, before Ramadan, this is the last session and we will again start after the Ramadan and we will have again the pediatric session. We are actually impressed by your session. Can you make any comment about our session?
I have no words because I am not at that level that I can comment like in Rafique sir's presentation. But I can say that the motivational word that he mentioned in last, that is the best part of these things. That if I took one thing or can apply in my patient and I can save my patient, that is the target, and that is the main things of this session. And thank you, sir, all of you, that you all acknowledge the pediatric ECG and pediatrics things, because that is also totally different. I must appreciate you all that anytime we can seek your help, you help us, because we have less exposure in ECG. And I also, you, Wadud sir and Rafique sir, anytime I can, if put an ECG and you help me, that is the best thing and excellent thing for me, sir. Thank you, sir.
Appreciation, Aroma. AM Shafiq.
Thank you, sir. Actually, nothing to say. And this is definitely my privilege to be here to learn many things from Rafique sir and all of the panelists as well. Really good. And I enjoyed a lot. Actually, I'm really sorry that I could not join previously in many classes. So it is a privilege not for me as well, for the whole nation's cardiologists to learn ECG in this forum. And definitely, inshallah, this forum will go on so that we can learn more and more ECG from Rafique sir and all the panelists, Bangladeshi panelists as well. Thank you, sir, for giving me the opportunity to learn from you, sir. Thank you.
Jamil.
Sir, actually, I always learn from the talk of Rafique sir, and since 2004, and he always admires me, I should say. If anywhere where I'm not present, he always say good things of me. I don't know why he likes me so much. And I learn always from his talk. When he was in NICBD, while we were starting EP in Bangladesh, we learned a lot of things about EP, and I'm practicing those on my patient now. And regarding this ECG study group session, in each Saturday we are doing, every day I learn so many things. Still, I feel like a student. Thank you for organizing such a session. Thank you.
So, finally, Abdul Wadud Chowdhury will wrap up the session. But before that, I have got two sentences. Rafique sir, actually, over the last 1 year, there are more than 40 sessions. Each session lasted nearly 2 hours. Initially, we had got more than 200 participants. Still now, we have got fixed participants more than 100, live as well as in the Facebook. Rafique sir, you are the life of the session. You are our philosopher. You are our teacher. You are our mentor. Actually, I personally admit I am learning, still learning. I think every day I very little about this. Still we are learning. Even today, I have learned a lot. So you are our teacher and you are life of the session, sir. And Rafique sir, you have added life to the life of this session. And Dr. Hafiz added new dimension to the session. And both of you has given an excellent forum for the discussion of the ECG. And we must congratulate our another foreign faculty, Dr. Arun Maski, and his team from the Nepal. Sometimes they have joined with us and they have given the new dimension again. And finally, our national participant, that is faculties like Jamil, then Mohsin, then Shafiq, and Govindo, we must admit, that is the Govindo, and our Shahabuddin, Professor Shahabuddin from Sylhet, as well as Anisul Awal from the Chittagong, many more, Roisuddin Mondol from the Rajshahi, always inspired us. And finally, we have also found a good team of the pediatric cardiology, particularly Naharuma and the Rezwana Rima and also our madam also. We have got a new insight into the pediatric ECG. So this is the ECG forum. And finally, I must congratulate. I am working with Professor Abdul Wadud Chowdhury. He is a very, very, very popular teacher, and his popularity has added another new dimension to this session. So we want to continue this session. Just there is a break for the 1 month, and if the participant want, we can arrange a special session during the Ramadan if the participant want. So this is the comment from my side. Professor Wadud Chowdhury can wrap up the session, and finally I must congratulate Rivu. You are wonderful, and there is no parallel to you, Rivu. Thank you very much. And Professor Wadud Chowdhury, I am inviting you to wrap up the session.
আথার ভাই, আমাদের খুব ভেটারেন কার্ডিওলজিস্ট নুরুল ইসলাম ভাই আছেন নারায়ণগঞ্জের।
তাই না?
হ্যাঁ, নুরুল ইসলাম ভাই, আপনি আনমিউট করে একটু কমেন্ট করেন। আমরা খুবই আনন্দিত যে আপনি আমাদের সাথে আসছেন। নুরুল ইসলাম ভাই
মিউট হয়ে গেছে।
মিউট হয়ে গেছে। হ্যাঁ, এখন
হ্যাঁ,
ঠিক।
এবার ঠিক আছে।
Thank you very much, Professor Wadud and Atahar Ali and others. Actually, learning, there is no end. So, in every aspect, we are actually there's a space to learn everything, and thank you very much. You are involving us in this aspect, and a very common thing, ECG, that is the starting point for the cardiologists and the general practitioners also, for to identify the what the ECG comments. So thank you very much, and we will be waiting for next month to participate with you. Thank you all for a nice session. Thank you very much.
Thank you, Nurul Islam bhai.
রইসুদ্দিন ভাই আছেন রাজশাহী থেকে। রইস ভাই, would you please unmute? Royce bhai, are you there? Yes.
Yes.
Yes, Mondol.
We want
Yes.
to...
Welcome, Mondol.
Hey. Atahar Ali bhai and Wadud Chowdhury and all the organizers, thanks very much, because every sessions, every year we are learning lot of things, and ECG really it is a new things we learn every day. So thank you, Rafique Ahmed sir and Professor Atahar Ali, Wadud Chowdhury, and Jamil bhai, and all panelists and all the participants. Thanks very much. And we hopefully will meet after Ramadan. So everybody, আমি এই করোনা টাইমে সবাই যেন ভালো থাকে দোয়া করি, আমাদের জন্য দোয়া করবেন।
অবশ্যই।
Thank you all. Thank you everybody.
I'm going to wrap up the session. Today, we again have seen how a simple problem can be beautifully presented, can be discussed very meaningfully, and how all of us can learn from the wisdom of a very, I should say, a very প্রজ্ঞাবান মানুষ। রফিক স্যার, ধন্যবাদ আপনাকে। আমাদের অন্তর থেকে, আমাদের মস্তিষ্ক থেকে শুধু আপনি আমাদের মাথার মধ্যে জিনিস ঢুকিয়ে দেননি, আপনি মনের মধ্যেও আমাদের ছাপ রেখে গেছেন। এই দেশের সন্তান আমরা, এই দেশকে সোনার বাংলা করার স্বপ্ন আমরা সবাই দেখি, এবং কালেকটিভলি সেটা সম্ভব। আপনি সেই উদ্দেশ্যে কাজ করে গেছেন, কিছু পাওয়ার জন্য না। এবং আপনাকে দেখে আমরাও যেন ইন্সপায়ার্ড হই। এই যে আতার ভাই বলছেন মেন্টর শব্দটার অর্থ কিন্তু অনেক সুগভীর। আপনি সুনিশ্চিতভাবে এই শব্দার্থগুলো আপনার অস্তিত্বে ধারণ করেন। আমরা কৃতজ্ঞ। We are so much grateful to you and all the audiences for your lively presentation, all the faculties for your so much beautiful contribution. All of us are together learning, progressing, and serving better our patients. Hopefully, we shall continue the same thing, this beautiful journey. After Ramadan, we'll be continuing again. And hopefully, we'll find the eager audience waiting for us at that time. Thank you, everybody. And Beximco, Rivu and your team, Kamrul and other, thank you so much. You have been always with us. With so much difficulties, you are still continuing with us for this almost 1 year. And from the team from abroad, Orun Maski, and previously from when we are doing it in the afternoon or evening, those from Malaysia or Maldives, they joined us, and that actually gave us inspiration. Hafiz Bhai and other faculties from abroad, they have given the glamour to these sessions, and as Atahar Bhai was saying, another dimension. সবাই মিলে আমরা যেন ভালো থাকি, সবাই মিলে যেন আমরা জ্ঞানের, সত্যের, সুন্দরের চর্চার অভ্যাসটা ধরে রাখি, সেই আশা নিয়ে সবাইকে শুভরাত্রি।
Sir, I have a humble request, sir. Sir, we are daily encountered a problem, ECG. In that case, when we communicate with sir, Professor Wadud sir, Professor Atahar sir, Jamil sir, if get any response, it's very much helpful for us.
You're always welcome, Govinda.
আমরা সবাই
Send me the ECGs.
এটা রফিক স্যার তো
Try to
Continuously,
give my comments.
we are facing so much difficult ECG, so varieties of ECG. And ultimately, special thanks and gratitude deserve ECG study group, a largest academic group. We have learned a lot from this academic field. Salute, sir. Rafique sir as well.
Thank you.
and also
Thank you.
others.
গোবিন্দ, আচ্ছা
Thank you,
গোবিন্দ
sir.
বলি, আমার মনে হচ্ছে স্যার, আমি রফিক স্যারকেও রিকোয়েস্ট করবো যে স্যার আমাদের ইসিজি স্টাডি গ্রুপের যে ফেসবুক পেজ আছে,
Sir,
সেখানে আমি রিকোয়েস্ট করবো, গোবিন্দ তুমি মাঝে মধ্যে ইসিজি পোস্ট করবো, এবং আমি রিকোয়েস্ট করবো যে সবাই ইসিজি পোস্ট করতে পারে,
জি স্যার,
আমরা
আমি
আমাদের ডিসকাশনটা ওই জায়গাতে কন্টিনিউ করতে পারি,
জি
আমরা
স্যার,
সবাই পার্টিসিপেট করবো। এবং
Yes.
আমি রিকোয়েস্ট করবো আমাদের রফিক স্যার এবং হাফিজ ভাই যদি পারে ওইটাতে আমাদের ফেসবুকে আমরা অ্যাড করে নেব,
জি
নিলে
স্যার,
সবাইকে ইয়া করবো। এবং ফাইনালি আমি বলি স্যারকে যে স্যার, আমাদের শুরুতে যেটা স্লোগান ছিল, যেটা আমাদের অবজেক্টিভ ছিল, যে জুনিয়র এবং স্টুডেন্টদের ভিতরে ইসিজি ব্যাপারে একটা মানে ইন্টারেস্ট গ্রো করা, আমার মনে হয় সেই দিক থেকে আমাদের অনেকটাই সাকসেসফুল আমরা হতে পারছি আর কি। তো আমাদের এই মুভমেন্টটা কিন্তু চলবে, এবং তুমি যেটা বলছো সেটা আমাদের ইসিজি স্টাডি গ্রুপে প্রেজেন্ট করো, আমরা সবাইকে ইনক্লুড করে এটা কন্টিনিউ করার চেষ্টা করবো। এবং আমাদের স্টাডি গ্রুপে যদি এরকম কমেন্ট আসে, আমরা দরকার কোনো স্পেশাল সেশন করতে পারবো। স্যার কিছু বলবো স্যার?
থ্যাংক ইউ। না রিভু, স্পেশাল থ্যাঙ্কস রিভু, তুমি মানে রিভু যে কাজটা করছে কি, যে স্টেইং উইথ আস, আমরা তো এই করতে
Thank
পারছি
you so
উইথ
much,
স্মাইলি
sir.
ফেস।
Thank
থ্যাংক
you
ইউ
so
ভেরি
much.
মাচ।
You always
Thank you.
stay with
Thank
us, and she coordinates with all the faculties, sending SMS individually. Thank
Thank
you.
you so much, sir. Means a lot. Means a lot. Thank you.
ওকে,
Thank you.
তাহলে ক্লোজ করতেছি, কথা হয় আবার দেখা হবে। আসসালামু আলাইকুম।
জি স্যার, ইনশাআল্লাহ।
Assalamu
হ্যাপি
alaikum.
রমাদান স্যার, রমজানুল মুবারক,
Happy
সবাই ভালো
Ramadan.
থাকবেন।
জানো না।
Good night.